So when we're looking at the catch cohort data, there's the good side and the other side. So the good side is giving optimal therapy, full doses of methotrexate from the beginning, whether it's parenteral IM sub-Q or oral, and or in combination with our conventional synthetic DMARDs, double or triple therapy, hydroxychloroquine, sulfasalazine, maybe leflunomide. What we find is that a lot of patients get into a low disease activity or even a remission, DOS remission, or a tighter SDI or CDI remission. And we have one of the highest remission rates of all the cohorts if you compare to the French cohort, ERAS, if you compare to the Netherlands cohort, the British cohort like Norfolk, etc. When you look at all the other cohorts, we have the highest percentage of deep remission, and that is in general in many patients without advanced therapies because we're optimizing our conventional synthetic DMARDs effectively at the beginning. The other things we found over the years in CATCH are really two important things. One is that on average, we're getting the patients in a bit earlier, but we do hit the wall. You can't get everybody in at, say, 2 weeks. So at the beginning of CATCH, they were on a median of 5 months from first fixed symptoms. Now we're at least a month or a month and a half earlier than that. So around 3.5 months. So if you build it for an early arthritis clinic, they will come, you'll get the referrals earlier and you can prioritize them. So what's the dark side of all this? Even though most of our patients do well, and we see every 2 or 3 years, more patients go into low disease activity or remission compared to when we first started CATCH quite a long time ago. So every few years, we have more people hitting these high bar outcomes. The dark side of all rheumatoid arthritis treatment is that there's still about 1 in 5. So we're talking about 20% of our patients that are recalcitrant. We give them effective CS-DMARDs, we add or switch or move on to advanced therapies, whether it's say a TNF, a JAK, or other advanced therapies. We might be injecting the joints. We talk about adherence. We might be giving multiple meds at the same time, triple DMARDs and an advanced therapy, or even occasionally quadruple, methotrexate, hydroxychloroquine, sulfasalazine, leflunomide, and then adding something. So there are still patients, and they're not rare, they're not the majority, but 1 in 5 patients where we really are unable to treat them. And I suspect a couple things are going on. I don't think it's usually adherence, although if you don't take your drugs, not surprisingly, they don't work. It's not usually adherence. It's probably patients are rapid metabolizers, and they probably have on synovial biopsies a more fibrotic pattern, which is very difficult to treat on the current RA drugs. So what I foresee in the future is that we'll use single cell sequencing, proteomics, etc., to try to profile these patients who don't do as well, so that maybe we can find the targets and the right treatments to help these people go into a better disease state. But right now we are kind of shooting in the dark, and I think we can learn from oncologists who do all sorts of typing. What's the cell type, what's the degree and extent of spread, etc. I think we can learn from them.